Hello, my name's Dave Zobek. I'm an educator, respiratory therapist, and a pulmonary function technician. I am going to cover some information that will help you in the interpretation of pulmonary function tests. In the first part, we're going to cover the graphs and measurements that are in a pulmonary function report. That is going to help you better understand how to interpret these complicated tests. Here you see a typical pulmonary function test. At the very top will be the patient data, name, hospital number, whatever. Then in it you will see the height, weight, age, sex of the patient. That information is necessary so that the program can calculate out the predicted values for every one of the measurements that we're going to be looking at. If you move down to lung mechanics, these are measurements that indicate flow rate as the patient exhales. And with that exhaled air, we can kind of assess where that came from and what is the area of the lungs that are having problems. Now, if you move to the right, you'll see columns of numbers. You'll see the actual, the predicted, and then the percent of predicted. It's the percentages that we look at to help us interpret the pulmonary function test. If you continue a little more to the right, you'll see the post-bronchodilator information. We give the patient a bronchodilator and then retest them and see how well they've improved or not improved. Back to the lung volumes, we have a section that shows the volumes. Volume is what we look at to determine restrictive problems. Next is diffusion. Diffusion is the measurement of how gas moves from the alveoli into the blood. And then lastly, the blood gases. In spirometry testing, normal predicted values, which are based on age, height, gender, and possibly even ethnicity, are taken and compared to the patient's actual measurements, and we get then a percent of predicted. Incidentally, males of the same height and age have larger lung volumes than females. Differences based on ethnicity sometimes is corrected by 12 to 15%. I'm not sure if this is a valid type of change or correction to the lung test. Here you see the two graphs that are displayed are found in a pulmonary function test. We have the patient take in a great big deep breath in and blow it out as hard as possible. As the patient is doing this, the spirometer measures this exhalation, and it will display it in two different ways. The volume time curve, which gives us the ability to measure flow rates, which are liters per second, then calculated into liters per minute. The second one, the flow volume loop, is the one that will show us the inspiration on the bottom with the fast, rapid exhalation all the way out till they can't get anything more. The flow volume loop is the one that gives us the ability to see the patient's peak flow. It's hard to get anything as far as flow rates because there is no time indication on it. As we look at that loop, it extends off to the right, and the farthest point right is the forced vital capacity. As we have that patient exhale as fast as possible, we do get that volume time curve. And as I said, it gives us the key measurements for flow rate. One of the most typically looked at is the FEV half second. And so we look at that because in the FEV half second, we should have at least 50% of the vital capacity. If not, then you're having issues with exhalation, and issues with exhalation is indicative of a obstructive problem. So if FEV half second is less than 50%, it can indicate an obstructive problem. The FEV1, when it's reduced, can give us a good indication of the severity of obstructive airway problems. However, if the forced vital capacity is smaller than the predicted value for FEV1, that could also indicate a restrictive problem. Now, we can see the FEV1 in two places, on the volume time curve, but also on the loop. The computerized loop will show us a little tick mark going up, which is the point of the loop where the FEV1 is. And so that gives us a good indication of how the patient is doing when you look at the loop as well. In pulmonary function testing, you cannot look at just one test and make determination of what's going on in the patient's lungs. For instance, forced vital capacity can be decreased in both obstructive and restrictive measurements. The reduction is going to be greater in the restrictive problems, but we also can look at the rise of the volume time curve. So let's look at these graphs down below. You see here on the left the loop of a normal measurement of a patient would be in blue, and compare that to a restrictive problem where you have basically the same peak flow. You can see how that goes up to the top, but the movement across the volume line is much less than a normal value. In the obstructive problem, the peak flow does not go up as high as the other two, but the volume can sometimes be fairly close to a normal volume. Now, if you look over at the volume time curve, you can see how the normal in blue rises very quickly and gets up to the maximum level, whereas in obstructive, it rises to the maximum exhalation very slowly, much slower than normal. In restrictive problems, the rise is almost as fast as a normal, but it does not go as high on the volume measurements. As I said earlier, as we exhale that large, deep breath as fast as it can come out, the flow volume loop is a good visual of what's happening. So if you look at this loop, at the very beginning, we see the air in the large airways being exhaled in the first second. This is followed by the air coming out of the medium-sized airways, and then at the very end of the exhalation, we're measuring the air from the small airways. And so when we get this information, we can look at what's happening in the lungs at different points of the patient's exhalation. So in that first measurement, that exhalation as hard as we can, we get the peak flow. And that's, if you look at the loop, at the very top, highest point of the loop. We also measure the FEF 200 to 1200, and that's the first liter of air coming out of the lungs. And that shows us, again, those large airways, and then the FEF 25% is the final portion of the air in the large airways. So if we have a decrease in these areas, in these measurements, it indicates a large airway obstruction. But it can also be due to the patient's lack of effort. Pulmonary functions really must be done with full cooperation of the patient, and the therapist, the technician, has to really work the patient to get them to exhale as best as they can. Next, we're looking at the FEF 25-75 and the FEF 50%, and that is the middle portion of the loop. That's those medium-sized airways. And then lastly, the FEF 75% to, and also the FEF 75 to 85%. And this is in the very last portion of the loop, and this is where we're looking at the air finally coming out being the small airways. So the patient is exhaling out, and we're getting them to squeeze down, push as hard as they can until we don't see the patient moving any more volume out of the air, out of their lungs. As I said, the flow volume loop is a visual representation of the patient's fast exhalation. So on the left, you see a normal loop in red where the peak flow rises up and the FVC moves all the way to the right. So you get the widest point of the loop is your FVC. Now, if you look at a restrictive loop, it's going to have a almost as high of peak flow, but you're not going to see that volume as good as the normal loop. It's going to be a lot less. So you get this squashed down looking appearance. Now, in small airways obstruction, you get this loop that is not as high in the peak flow and not as far to the right as the normal volume. But then again, because this loss of flow from the small airways, you get this scooped out looking loop. In these three loops, you see something totally different. The first one is a fixed large airway obstruction. This is where the airway is narrowed or blocked, and it's affected both on inspiration and expiration. These can be caused by tumors, foreign bodies, or things like tracheal stenosis. A second one is a variable thoracic large airway obstruction, and this one causes the exhalation flow, the expiratory flow, to be decreased. And this is causes that flattening of the expiratory loop, and so the obstruction is occurring seen in tracheal malacia and also tumors. Tracheal malacia may cause weakening of the tracheal walls, causing them to collapse when we have forced expiration. The extrathoracic loop that you see is where the obstruction is above the chest. You have narrowing causing a difficulty with inspiration, difficult in inhaling. These thoracic obstructions can be seen in vocal cord paralysis, goiters, tumors, or other upper airway problems. Maximum voluntary ventilation is a different type of breathing maneuver. This is where we have the patient breathe a medium-sized breath as rapidly as they can in and out for 20 seconds. Some people will call it huffing and puffing. It'll sound much like this. And you can see it would be reduced in moderate or severe airways obstruction. The MVV can also be reduced in restrictive conditions, mostly because you don't have the size of volume. MVV is reduced in interstitial diseases and COPD. It's also reduced if you don't have a cooperative patient. Diffusion capacity is the measurement of the gas moving from the alveoli into the blood. Now, this is basically an indicator of alveolar membrane thickness. That's what we're concerned about. But in some cases where, like carbon monoxide binds up the hemoglobin, the measurement can also be low. It's not an indicator of restrictive obstructive disease. It can occur in both of them as well as normal measurements. And it's a uptake of gas into the blood. And that's the essence of this measurement. Now, diffusion capacity will be reduced in emphysema, where we have loss of alveolar tissue. You just don't have enough lung tissue there. It'll be reduced in fibrosis, conditions like asbestos, which has caused thickening of the lungs. It'll also be reduced when you have severely small lung volumes. It also can be reduced in pulmonary embolism because you have less lung space that's functioning, getting perfused. It will also be reduced, as I said, with high carbon carboxyhemoglobin, and it'll also be reduced when you have a low hematocrit. Now, this image may help you visualize where each of these measurements are coming from. If you look at the FVV1 to FVC, the ratio that's right on the top, and the FEV1 second, that's measuring the obstructive condition of the lungs, and that's the air, all of the air coming out. Moving down the airway, we're picking up now at peak expiratory flow rate, FEF 25% and FEF 200 to 1200. These are the measurements at the large airways. And further down, as we exhale the air out, then we're picking up the air in the small airways, and we detect that by the FEF 2575 and the FEF 50%. At the very base in the alveoli, at the bottom of this image, you can see where the DLCO is. That's the diffusion. It's not the bottom of the lungs, but it's the farthest reach into the alveoli to the alveolar membrane. That diffusion is measured or identified if there's a problem. Now, on the left side, you can see that if the lung volume is larger or smaller, that'll be detected by the FVC and the TLC. Looking at the pulmonary function test report section by section, the first section we're going to look at is lung mechanics. All of these measurements indicate or are measurements of flow. In the first section, we have the pre-bronchodilator, we have the actual and predicted, as well as the percent of predicted. Now, if we want to know if a bronchodilator is affecting or benefiting the patient, this is where we would look in the post-bronchodilator section. And we look at the percent change, and most of these we want to see a 15% improvement. The second section is lung volumes, and these measurements help us understand if the patient has a restrictive problem. And the key ones in here is going to be the FVC and the TLC. Now, if they're doing a body box measurement for total lung capacity or FRC, we're going to see it noted as TGV. So TLC and TGV are basically the same thing, total lung capacity. The last section is the lung diffusion. Of course, we just got done talking about that, indicating the change in the alveolar membrane. And then we also have the blood gases, which kind of go along with diffusion, but we want to look at the blood gases in relationship to the pulmonary function testing. I believe a lot of respiratory therapists throw up their hands and just walk away when they look at a full pulmonary function report. It is very difficult to know what is important and how to interpret all of this information, all of this data, all of these measurements, the pre, the post, the actual. So what I'm going to do is show you a simplified way of doing pulmonary functions. There are 8 key measurements that you should focus on. FEV1 second to FVC, total lung capacity, FEV1 second, FEF 2575, FEF 200 to 1200, DLCO, FRC, and residual volume RV. If you look at these 8 measurements and know what you're supposed to be looking at, your interpretation will be dead on. Well, we're at the end of part 1, and hopefully you'll join me in part 2, because that is where I tell you how to use these 8 key measurements, what information you need to draw out the actual interpretation of a pulmonary function report. Thank you. I hope you enjoy this series and have a good day.